has overstayed without putting adequate measures to implement this proposal as it was originally intended. So that will be my first reaction. I don't know, can we all highlight our whole reaction so that you respond, or you will respond to those ones first? Yeah.
Let me say, with your permission, can we answer now?
Yeah.
Yeah. Let me say that I will give the directors to give us the figures if they agree. But at the onset, let me say we have a cancer registry in Longisa, which is a national cancer registry. So there is no duplications. Once you are captured anywhere else and you appear in Bomet, you've been captured in Kenya. So we have that cancer registry. So figures that we get from our cancer registry feed to the national. So the national figures, and even for Bomet, can be quantified. Number two, when we say MCH, it's an abbreviation for Mother and Child Hospital. So there is the clinic for MCH. Sometimes they can be very confusing. As I said, when Governor Joyce visited Longisa, there was a very serious congestion. In fact, Chair, if this committee has a chance to go at 8 in Longisa, maternity, you will be surprised. Even though the national government said there should be no sharing, public hospital cannot send patients away, especially the ones who have come to deliver. So there is that serious congestion. We thought that would be a good thing to do because they are congested not just to deliver. Even in the female side, they have come to seek services that are cancer related. So when they are in the ward, there could also be patients who have cancer problems. We have patients with cervical cancer in Longisa, and they can be managed in this facility because there will be more space. On the timeline, especially stating that we probably have overstayed, the resources have been constraining. But what we've done, because as I stated, cancer cannot wait for you to construct, then they appear. They are there already. So what we did was to collaborate with the national government, and they assisted us to work with MTRH to address some of the cancer issues. In fact, they helped us to have a chemotherapy center. We are among the very first that were given that chance to have a center where patients, instead of going to Eldoret, can be done in Longisa. We also build up patients when they are preparing to go to MTRH to have the initial evaluation, like giving transfusion, which we've been supported to have a blood bank or blood services in Bomet. So we are working. This has been necessitated by the fact that this is a financially challenged approach, but we could do it progressively. So establishing of mother and child can be part of addressing having the national the cancer hospital. So let me ask the directors if the statistics given agree. Maybe Dr. Birech.
Thank you, Chair, and thank you, Waziri, for this. Let me just add to what you've just said regarding what was asked. If nothing has been happening ever since. One thing that I would wish to build to the committee is that cancer care is multidisciplinary. It involves many members in the healthcare provision system. It involves many facets within the healthcare system. In Longisa, when we looked at our HR capacity as at that time, we were not able to do a huge cancer center that people see what MTRH is doing now. What MTRH has now is a product of probably 20, 30 years growing that unit. What happened in Longisa then was we started as a small section that we were giving chemotherapy. And when the former governor saw what we were doing, she pushed resources, including trainings, for some of the staff that we have now. As it is now, Longisa has a resident oncologist, which no other facility has around here. And the resident oncologists are too, which is a product of time in training and convincing even people to come to train and work within the county. Sometimes it becomes very difficult for us to retain people when you have nothing. So we created the nucleus, and we are happy that facilities chair like MTRH used to send a complete unit of oncologists, nurses, pharmacists, psychosocial support system, that they used to come to Longisa for 2 days, which was funded exclusively by MTRH for almost a tune of almost 2 years that they used to do that. We even had the luxury of having consultants from Kenyatta National Hospital who used to come to MTRH, including Dr. Nyongesa, a very prominent oncologist who used to come to Longisa. So a lot of work has gone on in terms of building progress, and by the time now we are leaping from a small unit that used to see a few patients to seeing to having a resident oncologist, to having chemotherapy that has been started, that patients come for chemotherapy, to being registered as a cancer center by NCI and even being recognized by SHA and NHIF previously. So there is a lot of work that has gone forth to the level that we are now. Even when we talk of the numbers now that we are seeing in a year, we've been seeing close to last year we saw almost 500 patients. Those are now the numbers that are there. But this is happening within an integrated system. Back to the question, Chair, Honorable Chair, that you asked regarding statistics. Bomet is one of the areas that has a high incidence of esophageal cancer, which mistakenly called throat cancer. Esophagus is the food pipe. That is the leading cancer in Bomet, followed, of course, by cervical cancer and breast cancer, and then prostate. Those ones their numbers are not so high. So if you look at the Kenya Health Information System, the numbers have been rising based on what we are recording. In 2021, we had about 313, 2022, 360, 2023, 661, and the numbers are rising. Why are the numbers rising? We would ask ourselves that. One of the reasons is that once you have a center that specifically deals with this, Chair, the numbers tend to come up. People come seeking care, and by extension, you start seeing your numbers, you capture more patients going up. Number two, the investment by the county government and by extension the national government in diagnostics. And these diagnostics come in various forms. Now we have CT scans, we have other diagnostics like MRIs around, not far from here, because MRIs are available within Kericho County. Those and also the numbers of doctors and other healthcare workers that the county has invested in have increased the number of patients who go to hospitals, and the high index of suspicion increases. So these patients the diagnosis is being picked up. However, the only other drawback is that the stages of where we're diagnosing our patients, we are diagnosing them as late stages, stage 3, stage 4, where now you start getting mortalities and deaths occurring. Why? Is because people presenting in late. But we are looking at a time where we are going to reverse these trends because of the increased coverage of healthcare facilities, increased early diagnosis, because we've also invested in training. Remember, we've never had a resident pathologist in this county, but now we have one who is almost completing his training. So it's something that, Chair, I think the investments are going to be ripe. And again, if you start a cancer unit without your requisite nucleus of your own staffing, it would become a very big problem to attract, retain, and also have these officers, because there were few, and many people are trying to keep them in bigger cities and bigger towns. But we are happy at least we have our own who are acting as a nucleus to grow this unit. That would be my submissions, Chair. Thank you very much.
Chair, I want to say, basically, having a complete and operational oncology center, like my colleague has said, not only goes to the investment in infrastructure. The most critical part of it is the human resource. And when we speak to the issue of the human resource, let me just paint a small picture of what Pirech has highlighted, then we didn't have an oncology center. Now we have one that last year attended to over 520 patients. Then we didn't have anyone trained on oncology related issues. Actually, Dr. Omonde is a trained pharmacist oncologist, and is the one actually who took the effort and the risk of initiating the cancer center that we have in Longisa. So we now have one. We didn't have an oncologist then, now we have one. We didn't have clinical officers who are trained and nurses who are trained on issues of oncology, now we have them. We didn't have someone in the laboratory who is trained in issues of screening, staging and all that. Now we have two actually who were employed recently. We didn't have someone on who was trained on issues of pathology. Now we have Dr. Macklin, who is actually coming back next year to ensure that at least we are making those stages. So effort has gone in. So what is remaining now is the hardware, which we humbly request this committee, if in the coming budget, the 2026-2027, if this, through this petition and through this committee, the county assembly can allocate for us an initial amount of around 300 million. We want to confirm to this committee that we'll be more than ready to start the construction of this comprehensive cancer center, even as a wait for the funding from other stakeholders. But if these resources will be availed, and then we'll eventually ensure that we have the dream of this cancer center. Thank you.
Chair. On human resource, I must say, to convince somebody to do pathology has been one of our challenges. In fact, when we advertised, we didn't get anyone. But convincing now Macklin to go and train, it has really taken time, and it takes 5 years to have such a person come out. Number two, we have a neurologic surgeon. So if there is a cancer of the brain, we have a surgeon who can operate and probably get a biopsy. We have a general surgeon or general surgeons, and we have a gynecologist. So those are the ones that Dr. Birech is saying. We work as a team. If you have an abdominal mass, the general surgeon can do something. So we build the resources. So the hardware is where we are. Thank you, Chair.
Thank you for that response. I want now to allow the rest of the members of the committee to react, beginning with Honorable Nato.
Thank you, Chair. First of all, I will start from the players of the petition, or the concerns that the petitioner raised. The main concern was the rising number of cancer patients and deaths. That include the one for Dr. Joyce Laposo. So maybe as a department, you should tell us the plans that you have in addressing the same issue. There was also a concern by the reason why the petition does to look into the matter is also something about the cost. They say that taking patients all the way to Eldoret is not an easy thing, so it is very expensive. So maybe you should also tell us what are the plans that you have on the same. They were also talking about the revenue. I chair finance, and I think we are more concerned also on the revenue issues. And they also raised the same, that we are losing a lot of revenue by taking patients all the way to Eldoret. And maybe Waziri, there is also a very serious concern from members of the public that the mother and child is constructed next to the referral hospital, which technically offers mother and child health care service. Will it be justifiable to construct the cancer center in the same location, which is closer to Referral Hospital, which hosts an oncology center. You also said something about the available land, the 9-acre piece of land is enough to accommodate both. So by telling us that we reject the petition, what guarantee are you giving us that if we reject this, you will also establish the cancer center as you said? And maybe Waziri again, maybe kindly tell us again if the Cricket Cancer Center was officially adopted by the county government, or was it just merely a public reference to the intended project? And on the same again, was the Cricket Cancer Center budgeted for? If it is yes, what stage did the project scope change? And then you also give us because what the petitioners did, they did a very serious research, and I also saw in the petition they included many patients coming from Kapletunda ward. They included most of them from Kapletunda. So I wanted you to give us the exact status of oncology and how the county government intends to address the increasing number of increasing demand for specialized cancer care. Thank you, Chair. I think those are
just a rejoinder to what Honorable Nata was asked. Now, confirm if there were donor funds. And what happens to the funds now that most of the donors, during the first fundraiser that was done, the funds were targeted specifically to a cancer center. Now, is it true that you redirected to the to the current MCH? Or there's really some donor funding? So respond to what Nat has asked and confirm if there were donor funds that were directed strictly to the cancer center, and whether you've invested in the MCH. Waziri.
Thank you. Let me start with the last one. Probably we don't understand where the donor funding was. This was done, there was some donor funding initially, where I'm not aware as a department, but maybe the fundraiser, there was a fundraiser initially when the concept was mooted, but it was not with the current administration. So we only had. Number two, let me just give a broad view of the approach. From the arguments the petitioner has given, it's like the argument is that nothing has been done, and we cannot belabor the fact that we've done something. First of all, to establish the requirements for a cancer center. Number two, provide infrastructure which will be supporting the main cancer center. That's why we are talking about the mother and child. Number three, the issue of rising numbers, and I agree with Dr. Birich. People probably are coming out more, and we are detecting some which we will not have detected. But the approach to cancer, even the national policy, states that there should be more on prevention. And that's why whenever we give talks, whenever we have outreaches, part of that beyond zero is where we screen mothers and we provide privacy. We screen fathers when they are there. So our approach has been on the prevention and emphasizing on primary prevention and primary care. So we are doing something about it. Number two, the cost is very high. As Mheshimiwa has said, that going to MTRH is very costly. But we've tried to mitigate that. And I said, some of the patients who go to MTRH probably just want to have a blood transfusion. So what we do, we collaborate with MTRH, we tell them we will transfuse here, we check their blood, they go with the results. So they go and they lessen their stay, they lessen the times they will visit, because they will just go for blood, then they come back, they go for chemotherapy. We are able to do and support that because we have a blood bank and we have a very nice working relationship with MTRH. Chemotherapy. When somebody has been initiated with chemotherapy, we tell them that they can refer them back to us. So we reduce their visits, and that also tries to mitigate the cost as we try eventually to have a cancer center in our setup. They also go sometimes to go and get a specimen removed. Some of them is just the bone marrow or a biopsy. We do them currently here because, as I told you, we now have specialists, neurosurgeon, we have a general surgeon, we have a gynecologist. There was even a time we had a urologist, although he was poached away from us. Those specimens can be removed here, and the specimen itself is referred to another lab, and we do. So we've tried to mitigate the issue of the cost, as Mheshimiwa is saying, and I agree. Part of the cost of cancer is not just the treatment. It involves even the lodging that you have to stay for 3 days or 4 days or even a week after the chemo. It involves having an extra person to accompany you, extra person or extra persons to accompany. It involves even people going just for results, going back. But with our current setup is that once the results are out, especially for biopsy, we receive the results ourselves and we convey it to the patient, and then we consult the teams there. And that addresses the issue of rising cases. We don't dispute that the cases are going. And I've said the approach to cancer is multi-pronged. Part of it is prevention, then the treatment. And then I agree revenue can go away from ourselves, but eventually we must save life as we try to progressively improve our part. Let me leave the other part, especially on the facility sitting next to the county referral and the adoption and the budget to the chief officer.
Thank you, Chair. Just to add, we will be getting additional endoscopy machines before June. That speaks to a deliberate effort in making sure that we mitigate on this. And Chair, Dr. Ari and the team will tell you that the most critical part of this treatment is early detection, early screening. And because that is the critical aspect of this, and as a department, what we have done, like Wasiri has said, is that we have expanded the screening services, not only through the Beyond Zero, not only through the regular medical camps that we are doing, but to high volume health centers, level 3s, so that mothers can be screened early in those particular facilities. With this, it speaks, if you look at the data before the establishment of oncology center in Longisa in the facilities, compared to now, it will show you a decline in some of these cases, and that can be attributed to the early detection. When we speak of 500 patients that are getting care in Longisa, that should speak something on how particular we are on this. Number two, Chair, to the best of our knowledge, we didn't get any budget initially from the previous government that was dedicated to this. So we don't have any budget that was forwarded to it or any account that we were told kuna pesa iliweka hapa for the oncology center. So to the best of our knowledge, we are not aware of that. Number three, the issue of the mother and child sitting closer to Longisa. And let me paint this picture, and I wish the committee will have time to also visit the facility. Longisa do deliveries in a month of up to 600 mothers. 600. That facility was constructed in the year 1993. The capacity then was to accommodate a maximum of around 64 mothers. Yes. And then with that number of 64, this again has been reduced because there was the creation of a theater that is dedicated for the maternity wing. Yuilikula, a section of it. There was a further dedication of the NPU, the expansion of the NPU. That has also reduced that section. There was also the creation of the Kangaroo section. That has also further reduced the capacity that hospital was initially supposed to accommodate. So as we speak today, if we visit Longisa Maternity Wing, beds have been placed along the corridors. There is no free space. Any free space has a bed. And every bed, we don't want to say this publicly, but we need to say is that mothers share those beds. So you'll find one bed with 2 mothers. This is not ideal, even when it comes to infection prevention. That is not only Longisa. Recently, last year, in October, we initiated deliveries in Bomet Health Center, just here in town. As of yesterday, mothers were also sharing beds in that facility. That is just to paint a picture of how dire the need of having an expansive mother and child hospital is. So that facility is not only timely, it has delayed. And any other further effort to derail its operational will only impact more negatively on the mothers, deliveries of babies. Let me say, Chair, as a county, and we don't have at the moment what we call the high risk delivery unit. This is for, again, the mothers who might be battling the issues of the cancer, high blood pressure, and several other issues. This facility will offer that. At the moment, we don't have a comprehensive ICU center. This is a center that even the oncology patients will require. In the new facility, we have around 12 and yes, we have 12 for adults and 8 for pediatric ICU center. That speaks to the delivery effort, not only to deal with the issues of the mother and child, but to also ensure that we are able to even further manage the oncology patients who require intensive and care services. So when it comes again to the mother and child, there is what we call shared resources. So that, for example, we can utilize the comprehensive lab in Longisa for the patients who are in MCH. We can utilize at the initial stages the CT scan that is available in Longisa for the same patients who are, so there are several shared resources. That is why when you go to MTRH, you'll find that their facilities are established in almost the same environment. When you go to Longisa, they are established in almost the same environment. When you go to Kenyatta National Hospital, all these big hospitals, all these facilities are put in close range because they share a lot of shared equipment and resources. And that is why mother and child comprehensive care units will be more ideal to have them in close range so that the other shared resources can be shared. For example, you will have say nurses, we will have the consultants that we have at the moment. We have one oncologist, we have a neurosurgeon, one of them. We have some around 2 general surgeons, and of course with one called Apollo, who is currently helping us. These consultants and pediatric oncologists, we have one. So they should be able to attend to the patient in MCH and Longisa without using a lot of resources and being available for this patient within the shortest time possible. Because when it comes to healthcare, again, the time of response time is very critical. So when you have the resources close together, it will be very ideal to share the equipment and also to share the human resources that we have at the moment without even using further resources like fuel and getting vehicles to transport the consultants that you have and the doctors to very far length. So it is only ideal. Thank you.
Thank you, Chair. On what Mheshimiwa said, Mheshimiwa member of this committee said the scope changed. I want to say that we have not changed the scope. As you listen to us, we have been trying to be progressive so that we can provide all other things, except maybe the very detailed linear accelerator and the CT scan. On the budget, I think there was a time we budgeted for the cancer center, only that I think the money was reduced. So it was not making I think there were other issues that came in and the money was removed from our budget. And to make a commitment that when we turn down this request to stop MCH, the guarantee we are giving is through the effort you've seen we've done, we are addressing the issue of cancer. So stopping that service will not be very helpful. It is to agree with the petitioner to even join us in the effort to address the same issue. So there is a guarantee, because already we've established, we've trained, and we are going to do the next step that is necessary, especially on infrastructure, when resources are availed to us. Thank you, Chair.
Because of time, I will be requesting that to the members and also the responders, let us limit time to 2 minutes each. So let us package the questions and responses to be elaborate, and we avoid repetition so that we...
Thank you, Chair.
Welcome, Mheshimiwa.
Bwana Waziri, I will take you back to that issue of fundraiser so that you can elaborate more. The petition has alleged that members of public contributed funds toward the purchase of land intended for establishment of a cancer center. Can you confirm whether the public fundraising occurred, whether such contribution were officially sanctioned or documented by the county government, whether records exist showing contribution, amount raised, and the intended purpose of the land acquisition? Again, if community members contributed financially toward land acquisition for cancer center, was the county government aware of such contribution? Did the county government enter into any agreement, commitment, or representation to the public concerning establishment of cancer treatment center at Jeb Cricket site?
At a rejoinder, we've checked on the CIDP cycle of 22-27. There was an intention or original intention to have a cancer center at Longisa, and the location is stated as Longisa Ward. Then the MCH was to be located at Youth Farmers, that is still at Longisa Ward, and the cost was to be 300 million. The cost of the MCH was to be 750 million. Now the first question would be, we are implementing the MCH outside the cycle, the intended cycle that was for 2017 to 2022, and now we've abandoned the cancer center, which was stipulated to be implemented within this CIDP cycle of 2022-2027. Additionally, the budgeted amount was 300 million. Maybe a starter figure was to be 300 million. And the County Department of Health has progressively been implementing other projects that could be even beyond that figure. Have the county have you engaged with the committee, the sectoral committee on this assembly, purposely to pursue or to push for the budgeting of the amount that you've stated, and also the budget committee? That is my question. Proceed, Waziri.
Thank you, Chair. On the issue of the fundraiser, I must say that we are not aware of what transpired during whether there was a fundraiser. What we are aware is that there is public land that is at what is the name given? There is a common name. Mungunyat is the other name. And I think we are all aware that there was a public participation when we did the mother and child. And there was agreement that we can have it next to that. Our plans have also included location of a cancer center at the same facility. In 2017, because I had the privilege of serving in this same administration, there was a time we were to construct the facility, mother and child, in Longisa. But the terrain was putting the cost, I think 1.2 billion at that time. And we wanted the support of the national government. They turned down because the cost was going to be extremely high. So we had to look for alternative land, and that is why we settled at the Chep Cricket, because the cost was going to come down. I think it came to around 300 something. So I don't have details on this 750 million, which you've stated, Chair. Maybe we can look at them again, given time. But let me just donate 1 minute to the Chief Officer. Then we back to you, Chair.
Thank you, Chair. One, let me clarify. We have not abandoned the dream of having the cancer center in the cycle of 2022-2027, just as you have stated. And we have demonstrated extensively the efforts that we have put in place. And that is why we requested, Chair, that by dint of this petition, if the committee, the budget committee, will allocate to us initial 300 million, we should be able to initiate this process. Again, the project of mother and child began in 2022. So it was within the cycle of 2017-2022. It's only that the project crossed over to the next financial year, because definitely this was a huge project. So we are obedient, we are loyal to the CIDP. I think we got the figures from the CIDP, which again is a wish list. You'll pick on them based on the resources that you have been given, but it has always consistent. It is in our CIDP, it is in our CFSP, and it's a request that even the members who brought this petition, currently there is the ongoing public participation on CFSP. And there'll be again a further public participation by the county and assembly on the CFSP and even the budget estimates. We also request them that they also voice their concerns so that together we can push for the allocation of the resources, because it is good to bring the petition, and it's also good for them to be to always be very active when it comes to allocation of the resources, so that at least this is not only a narrative that comes when. Thank you, Chair. And the last one, Chair. Like I said again, we'll request that at least let's get some of these members to be part of our committee, because from this petition it appears that they don't really understand the efforts that the county government has put in place to deal with the issues of the cancer. So if we can have some of them, at least they'll be in a position to appreciate the efforts, and together we can actualize this. So we can have them on board so that they can understand and they can speak from the point of information. Thank you.
You, Chair.
Honorable Marangi.
Thank you, Chair. I just want to ask only 3 questions here. What legal or administrative safeguards exist to ensure that public expectations linked to community supported projects are protected when project purposes are changed? Number 2, can you explain why the county government believes on MCH facility is higher priority at the site compared to the specialized cancer treatment facility? And the number 3, what assurance that the county government provides to residents that the cancer care infrastructure remains as a priority with the county health agenda. Thank you.
Thank you.
Wasiri?
Oh, yes.
Yes.
Thank you, Chair. When things are changed, it's normally through interactions with the users in terms of the service providers. And some of these things are advised by maybe trends within the national government. Like if you check currently, we are trying to prevent maternal and child deaths. And that is one of the driving force even, and it has been before. The statistics in Bomet have been very alarming for a county like ours. And part of the reason why the emphasis on mother and child was put has been aptly said by the team here that there is serious congestion. In fact, I would invite this committee to visit the maternity and even look at the newborn unit. The newborns are put in one cubicle. There could be 15 in maybe some incubators, and it really tells you that there is need. So whenever such occur, it is at the recommendation and in trying to fulfill the national interest. But whenever such a change is also required, we involve the executive through memos and even papers that are presented to gain support, especially where budgets will be involved. So we have finally a public participation, which will address what the community feels about what we are suggesting. But sometimes some of the suggestions come from the community and we take up. So it is collaboration and talking to each other. On the issue that we believe MCH is of higher priority, we've stated in our write-up that both are priority. And mother and child, I think the only unfortunate thing is this abbreviation, Mother and Child Hospital, is MCH. So maybe in the notion of some of our members out there, they think it is maternity and the child welfare, which we normally can even get in a health center. We are saying these are hospitals that address specialized conditions that affect children and mothers. And we have said this is provided and cancer would be included in such services. It's only that the portion of the specific radiotherapy and other allied departments have not been done. But the assurance that we are giving the petitioners that we are giving cancer priority is reflected on what we've done. You've heard about the human resource, where we've done all the best in terms of oncology and even the other surgeons who would be helping in the managing. You've heard about our referral system, which include physical referral of the patient or even specimen referral, which we've done. And the policies have come through this assembly, and they have given us an okay. So I want to assure the members of the community that we have followed the right channel. We believe we've talked to the right stakeholders to ensure that the cancer center is actually brought into life, and then we have that assurance that we are doing something. We are emphasizing on prevention, at the same time emphasizing on treatment. But if we can do more on prevention, we will reduce the burden. Thank you, Chair.
Maybe a quick
one more as we close, please.
Quick one, Honorable Chair. You mentioned something that currently you are looking for funds. You talked about Safaricom. You also talked about the Lipton. My question is, do you already have a blueprint on the said establishment of the cancer center? Or are you looking for funds and then you plan later on? So maybe you specify if you have a blueprint.
Over to you, Waziri.
Thank you, Chair. You heard that we went to the National Cancer Institute. We had a concept of what we want. And let me donate this to the Chief Officer to say something about that.
Thank you. we have a serious concept and a blueprint, and I think we can even share it. And as we continue with this, it's a very comprehensive blueprint. It brings the aspect of why we need it, the background information on why do we need the cancer center in Bomet. It speaks to the issue of the finances, how much resources will we require. It speaks to the issues of the human resource. It speaks to even the design of the comprehensive cancer center that we anticipate to have, and it speaks to the size. It's a very comprehensive blueprint. We have it, and we have shared this with all the stakeholders that are very critical. We have also presented it in various forums, and any other will also share this with this committee, so that when you also get other forums even outside this country, you can also share the dream of having this facility, because this, our hope and our belief is when we come together to actualize this, we'll even fast track the actualization of the same, and it will be the responsibility of all of us. We are just the implementing partner, but when it comes to the issue of getting the resources, I think it should be the aspiration of everyone, because cancer, if you are not affected and then you are infected, you have someone in your family. As there are the MCS, I know you attend several fundraising and tied to the treatment of cancer. So if we come together on this, we look for resources together, we allocate a budget to this, and then we'll be having the deliberate effort of making sure that we have a comprehensive cancer center, even with a few steps and the acquisition of the equipment that we have said that, like at the moment, a facility like Apkoros Cheptalal takes the biopsy from their own facility. That used not to happen, but what you are saying is if we have a central point, and then we'll have, and I think the biggest concern, Dr. Pirech and the team of the petitioners is, when it comes to cancer, some from stage, I think 3 or 4, then you'll require what we call radiotherapy. Those are advanced treatment to cancer. That is their biggest concern, because that is what will force this patient to travel from Bomet to either Nairobi or Eldoret. But because you're offering already chemotherapy for, and say, the lower stages of the cancer, that is not their biggest concern. So it's our. And Chair, this is our design.
Just we'll hope to share. That you share with us the blueprint, possibly before you leave.
Yes, sir.
And also you notify us whether the same has been subjected to public participation.
Yes, sir.
Okay.
So
if you can share to our clerks.
And this is one of the blueprints, and this was done in 6th of May 2025. Last year. It's over a year. And the blueprint that we have here, and we have always consistently shared this during the public participation of the CFSP and CIDP. We have also had, when we speak of public participation, Chair, we also do public participation among us, the healthcare workers, which is also a form of public participation. So this concept first was a product of public participation. So and it gives us the data of the cancer cases in Bomet and the trends for all that period, and it gives us the map of where we have most of these cases within the county. We have also done that, and then now we have a drawing of the cancer center that we expect to have, and then we have a budget to it. So we'll share this with the committee, because this is the document of the county government of Bomet.
Thank you. Thank you. So, because of time, we want to close it there, and we want to really thank you for honoring our invitation. Thank you for the submissions that you've made, and our humble plea as a committee is that you continue pushing and pursuing the dream to have this cancer center in Bomet, bring it to a reality. And we also appreciate the efforts that so far you've put in place, and we shall purpose to visit the Longisa Oncology Center and the MCH also. We shall also be visiting the Chep Cricket site, proposed site, so that we come up with an elaborate report, and we shall share with you once it is ready. So I'll allow Waziri maybe to do a last remark as we wind up.
Thank you, Chair. Mine is to appreciate you, Chair, for this wonderful time we've had. I want to appreciate the effort of the petitioners, because this has also helped us to bring out our plans and what we've done. I want to assure the public, the honorable people of the wonderful people of Bomet County, that the county government, through the leadership of our governor, takes health very seriously, and they are aware about the challenges of cancer. And it is in this aspect that we've tried to address their issues. So I want to thank you, Chair. I invite you to maybe if there is anything else, we can always talk about it. We can elaborate. We can provide information. So we are ready. We are ready now. I've started by sharing the plans to your WhatsApp group, Chair. So there are 3 documents that we've shared, and perusing through them, you will understand what we are doing as a department. Thank you, Chair.
So thank you so much. The session now stands adjourned. I will ask Honorable Nato to escort you somewhere so that you